afternoon or evening, and welcome to the second webinar in the International Knowledge Exchange Network for Mental Health series. I'm Nicholas Waters, and I'm the Director of the Knowledge Exchange Center at the Mental Health Commission of Canada, as well as the co-chair of the International Knowledge Exchange Network for Mental Health, or IKEN-MH. The IIMHL was jointly envisioned in 2012 by the Mental Health Commission of Canada and the International Initiative for Mental Health Leadership, with the aim of increasing the capacity for effective knowledge exchange in mental health by connecting people, ideas, and resources on a global level. The IIMHL is comprised of 10 leaders in mental health, featuring representation from the United States, Canada, New Zealand, Scotland, and the United Kingdom. The goal of IKEN-MH is to reduce the time from innovation to implementation, improve population mental health by building capacity, infrastructure, creating knowledge exchange research and tool development, use technology to enhance connectivity, and lastly, to increase the uptake of evidence-informed knowledge, which leads us to the IKEN-MH webinar series. The IKEN-MH is hosting a series of webinars over the next 12 months, featuring a variety of best and promising practices related to mental health and knowledge exchange. This will feature presentations from different countries to share international perspectives to colleagues around the globe on what works. We will provide us with your feedback after the webinar and update us on topics you might like to hear. More, as well as ask you to complete our post-evaluation survey after the webinar so that we can properly evaluate our series and adjust as necessary. Before today, it would be great if everyone could introduce themselves through the chat function, which can be found on the right-hand side of your screen. As shown on the slide in front of you, you should see a small chat box with a drop-down menu. This is where you can ask questions or comments either during or after the presentation. When asking a question, please send them to all participants rather than all attendees or all panelists, so that everyone participating can see the questions and conversation as it happens. I also mentioned that this webinar is being recorded and it will be archived on the Mental Health Commission of Canada's website following the presentation. A French version of the slides will also be available in the next week or two. A large number of participants, your phone or computer will be on mute. If you wish to ask a question privately, please send it to the host, which can also be found in the drop-down menu function. Of the IKEN-MH series entitled The Public's Mental Health and Wellbeing, a Local, National, and Global Challenge, How Mental Health Leaders Can Respond, will focus on population and community-targeted approaches to improving mental health and well-being for people, families, and communities, rethinking what we invest in, how governments need to work, how treatment systems are designed, and how outcomes and aims are shared and will be discussed. The presentations from the United Kingdom, Canada, Sweden, and the United States today, followed by a question and answer session. To begin, I'd just like to introduce the four presenters. From Sweden, we have Fredrik Linden-Krona. Fredrik is leading the research, evaluation, and improvement within the National Coordination Strategy for Mental Health at the Association for Local Authorities and Regions in Sweden. Fredrik previously worked in academia before commencing work on strategy, focusing his academic work on strategies for mental health promotion, systems, governance, and more recently on the role of national support structures and intermediaries. He's also a licensed psychologist and a member of the steering committee for the International Knowledge Exchange Network on Mental Health. Next, Gregor Henderson from the United Kingdom is the Director for Wellbeing and Mental Health for Public Health England. This is the national agency responsible for protecting and improving the public's health and for addressing inequalities. He's an advisor on Place to Be, a national children's charity working in schools across the UK to improve mental health. Previously, he was the director of the Scottish Development Centre for Mental Health in Edinburgh and led the Mental Health Development Unit in England, and he lectures across the UK, Europe, and internationally. Next, Priest from Canada is the director of the Population Health Promotion Innovation Division, Centre for Health Promotion with the Public Health Agency of Canada. Stephanie has over 15 years' experience in health policy development at Health Canada, including managing of the drug access policy and executive director of issues management. In 2014, Stephanie became the Canadian government representative on the International Initiative for Mental Health Leadership and is chairing the planning committee for the 2015 North American Leadership Exchange in Vancouver, Canada in September. Lastly, Gary Belkin from the United States is the Executive Deputy Commissioner for New York Department of Health and Mental Hygiene. He was previously the Medical Director of Behavioral Health in the Health and Hospitals Corporation of the City of New York. He also has served as an Associate Professor and Founding Director of the Program in Global Mental Health at the New York University School of Medicine. I will now hand it over to our first presenter of the day, Gregor Henderson. Over to you, Gregor.
Nicholas. Thanks very much, Nicholas. Welcome, everyone. What we're going to do is give you a selection of presentations, but what I'd like to do is give you some context and some key messages up front that we as presenters have been discussing. So we'd like you to think of these uppermost in your mind as you listen to the following presentations. This important seminar on population mental health and the challenges and opportunities that exist to promote the public's mental health and well-being. The message we'd like to share is that context obviously is key. Social, political, economic context within which you live and work is extremely important in relation to population mental health. We need to understand the interrelationships between mental health and other central dimensions of life, whether that's work, education, parenting. And with that sense of understanding interrelationships, we miss the opportunities to scale up for public mental health. The third is on scaling up, and scaling up is best achieved through partnerships and through champions who take forward initiatives in partnership with others. Fourth is that the mental health system really needs to set up governance arrangements that will translate some of these key messages and actions across broader issues. Our next is that radical change will require innovation and creativity to help in the scaling up, and we shouldn't underestimate the challenge of moving towards more social models for the public's health, and that leadership within that context needs to be alongside others. Finally, embedding and integrating mental health into the full range of population health activities is possibly one of the most important challenges and the way forward, and one of the key questions that raises for us on this webinar today is how do you shift the focus on policy, action and delivery from downstream mental health services, which are of course vital, to upstream promotion and prevention activities. First, okay, thanks. So I'm talking on behalf of Public Health England. We're a government executive agency. We're part of the Department of Health, which is one of our government departments. There's a population in England of 53 million. And key functions are health protection, providing knowledge and information, and improvement. And the mental health work sits in each of these three key functions, but is particularly based in the health improvement function. With 1,000 staff and a £5 billion annual budget, and we work closely with the National Health Service, local government, and government organisations. Next slide, please. A commitment to embed mental health in all that we do, and it's one of our underpinning themes. We recently published a document called Evidence into Action, and addressing inequalities and embedding mental health and in community approaches are the three underpinning themes that we see translating through all of our work. We have a core national team. We have 8 local centres plus London around England, a national knowledge and intelligence function, and part of that function is the provision of a national mental health dementia neurology intelligence network that basically makes data available down to local authority, local system level to enable population changes and challenges to be addressed with the use of good information and evidence. We also have a health protection psychological resilience team, a network, and that team is there to help support the psychological effects of major health challenges, whether that's Ebola or flooding or anything of that nature. So Mental Health and Public Health England is an evolving picture. Slide, please. Underpinning core themes for the public's mental health. The first is that embedding mental health, and that's both mental health as a positive sense of that word, and improving the lives of those living and recovering from mental illness are two of the major themes of embedding activity. So we think of our tobacco cessation work, when we think of our drug and alcohol work, we think of our work to address obesity, we're trying to embed both what that will mean for the lives of those living and recovering from mental illness, and what would happen if we were to truly put a psychosocial mental health slant in every single one of those activities and actions. Our actions is addressing inequalities and taking a community-based approach to our work, the development of relationships with communities and having communities at the heart of what we do, taking charge and control of their own health and the health of their local communities is vital. And that we have to address the key social and psychological determinants of mental and physical health, and that we wish to see a shift to well-being or a shift to wellness as markers of our success. Next slide, please. This is a of how we see mental health promotion and prevention. We have priority age groups on children and young people and older people, employment and working life, suicide prevention activity, and improving the lives of those living and recovering from mental health problems through mental health promotion activities, mental health prevention and suicide prevention, and improving lives, supporting recovery and inclusion. Next slide, please. We have a number of themes because we can't address public health priorities unless we also consider these themes of health equity, mental health and community. Problems related to tobacco, alcohol, the major challenges, for example, fall hardest on the most deprived communities, the excluded and marginalised. And people of all ages with mental health problems experience poorer health and die earlier from the major diseases. Health without mental health and good mental health helps to drive healthy lifestyles, behaviours and improved health outcomes. So the need to address key social determinants and adopt community-centred approaches is, as you know, vital in this regard. Next, please. This introduction. Well, we have a number of public mental health work programme areas. The first is around improving the lives of people with mental illness, physical health, and addressing the social determinants that shape their lives. Prevention across the life course with a particular focus on the best start in life, school-ready, school-based work, young people at older age. A national suicide prevention programme, which supports delivery of our national strategy. We give guidance, provide resources, give profiles of suicide prevention in local areas, and we provide a surveillance, real-time surveillance service. We also try and embed mental health and mental illness in the key areas of focus that our agency has, try and address some of the social determinants, and our major focus is on employment and housing. And for Wellbeing, we're beginning to establish the world's first What Works Centre for Wellbeing to help our shift to wellness, and I'll say something more about that later. Next slide, please. Activities, and this is where you can get more information after the webinar. For intelligence, we have managed to collapse over 45 major national databases with a certain number of indicators that look at each local area across England. You'll be able to see those 120 indicators for each local area. You can choose any one of those. You can do an intelligence report on each local area, which helps with the planning and the needs assessment that our local areas have in determining their strategies, actions and interventions for public mental health. We also have a big programme of work around improving the capacity and competency of leadership and the workforce. And this is a really important area, particularly for public health, as in our country there is not as yet competencies and capabilities identified in the major teaching and learning programmes for public health and mental health. And we'll spend the next 2 years to try and address that with our Faculty of Public Health and our College for Public Health, along with the Royal College of Psychiatrists. We have networks for support and learning across England, and we also have major social marketing activities. We try and underpin key mental health promotion and prevention messages. We're trying to action some of the something around 5 ways to well-being, and we're doing some digital marketing around sleep and stress. Slide, please. 5 ways, an evidence-based set of actions that were developed by the government's Foresight project, which takes a 50 to 100-year look at the future. And the Foresight report that was particularly memorable on this occasion was published in 2008, and it's called Mental Capital and Wellbeing. And these 5 ways to well-being have been translated into local action areas in a number of parts around England. Next slide, please. Slide, please. Have the next. This is a example of large-scale change across Liverpool, where they took the ways to well-being and they've managed to turn that into a decade of well-being, ensuring that their strategic priorities as a local area are developed around each of the 5 ways to well-being. So, for example, being active has a significant implication on their transport policies. Slide, please. Whoops, let's go on. This is Wellbeing Enterprises, which is another example of community wellbeing practice. And they have a number of different services that local practitioners can refer people to around social prescribing or community events or for wellbeing one-to-one reviews. And the initial evaluation from this work is extremely promising, and the outcomes have also proved to be extremely good for local residents. This next slide is to show that social relationships are one of the biggest factors in relation to not just subjective well-being, but also hard impacts like mortality. This is from a meta-analysis done by Holt Lundstad and her colleagues in 2010, and it shows that high levels of social relationships are helpful in decreasing your odds of mortality, in fact, as helpful as giving up 50 cigarettes a day. Next, please. A project I'd like to bring to your attention. It's a project we're doing with a social enterprise that is staffed entirely by people with experience of mental health issues, and the project is called A Day in the Life. And for 1 day each season, people with mental health issues are asked to blog about their experiences, what's been good that day, what's been not so good that day, to enable us to get some granularity into the well-being of those living and recovering from mental health difficulties. Each week, 5 of those blog posts are posted online, so you can get a sense of some of the key issues coming out for people living and recovering from mental illness. An analysis of the first season of blogging in the autumn. Issues like intimate relationships and sleep were extremely at the forefront of people's minds. One of the things happening in England at the moment is some questioning around psychiatry and the role to which it wishes to move from a diagnostic function to one where they shift to functionality. So instead of dealing with issues as diagnostic categories, looking at what people are able to do in relation to their functioning capabilities and desires, so whether that's for work, recreation, leisure, relationships, it's to build that co-production, improving and maintaining function rather than just responding to a diagnostic response. Next, please. There's a lot of evidence on what works, and you'll hear some more about that from some of our other participants. In the early years, schools, employment, older life and community. So the evidence base of what works is really actually quite impressive. Next slide. In England is synthesize this what works information and try and synthesize the best evidence to help create demand amongst those key agencies in our country, whether it's local government, the voluntary sector or business and others, on the distance between information, evidence and implementation, and create that virtuous cycle of dissemination, evaluation and dissemination. And encourage further research and further analysis. Next slide, please. Development of the What Works Centre for Wellbeing. It will be an independent charity by October, and you can have a look on the website and engage with the What Works Centre for Wellbeing on Twitter. And we hope that this will be a considerable advantage, not just for our country, but for other countries. And we have 3 initial areas of exploration. The first is work and learning. The second is communities. And the third is the contribution of arts, culture and sport to well-being. Next slide. Okay, I'd like now to hand on to Stephanie Priest from Canada.
And good day, everyone. Thanks for the opportunity to participate in the discussion this morning about mental wellness. Next slide, please. My presentation today is going to focus on an innovative population health program at the Public Health Agency of Canada that is applying and evaluating a population health research approach to help us better understand whether interventions are working and also why they are working. In cases, understanding why they don't work. I'm going to focus most of the presentation on what we are learning, because with this program, we're at a very exciting place where information, data, and evidence are starting to come in from some of our major mental health promotion projects, and just at the point of seeing some of the emerging trends coming forward. And I'd like to share some of those early results with you and talk about we're seeing about how this kind of work can shift to upstream action, as Gregor mentioned in his introduction. Next, please. A bit about the landscape in Canada. We often hear that everyone has a role to play in mental health, and this is certainly true in Canada. We work with different levels of government, with different responsibilities and roles. At the Public Health Agency of Canada, which is a national organization, we work very closely with provinces and territories who have the primary responsibility for delivering health services in Canada, including mental health services. At Public Health, though, we're also looking at mental health promotion and well-being with our partners, including provinces and territories. And this is the focus of our work in my group in the Public Health Agency. Ultimately, as funders and investors, we want to know what kind of impact our support is having across the country. And ultimately, we want to know how we can take effective and proven mental health promotion interventions to scale, and how we can share that with partners. Next slide, please. So one of the ways we are approaching this is through what we call our Public Health Agency Innovation Strategy. It was established in 2009, and it is essentially a population health funding model. The model is innovative for us, and I believe it still remains innovative. Prior to 2009, with our Population Health Fund, we were funding a scattering of short-term projects, and we weren't able to fully evaluate them to see the kind of long-term outcomes that they were having on a population. So what we did with the innovation strategy that I think is quite innovative, and you see on the slide here a couple of the key points, but I'll just draw your attention to a couple of elements. We looked at providing sustained funding over 5 years so we could really start to evaluate outcomes and long-term population health outcomes with the community. And started to evaluate the model or the process by which we were bringing these interventions forward, or communities were bringing these interventions forward. Public health problems don't impact all people and populations in the same way, nor do they come about due to the same factors. And that's why we're interested in understanding the role of health inequalities, including social, economic, and environmental conditions. And this really underpins innovation strategy. We have 2 priorities now instead of sort of a scattering of a number of public health priorities. The first priority is equipping Canadians with mental health across their life course. The second priority is achieving healthier weight. So I'm going to focus on the mental health promotion priority, but keep in mind, and I think Gregor mentioned this as well in their work in England, that there are all kinds of connections that can happen across healthy weight, healthy workforces, mental health promotion in communities, and we'll be looking for some of those synergies going forward. Next slide, please. So a little bit about the model. It's a phased approach. So phase 1, which was underway for about 12 months, was really a piloting phase or a testing phase for testing innovation. In phase 1, we had 14 projects and reached approximately 5,000 people across the country. Phase 2 then progressed for those interventions that were showing promise to an evaluation period of up to 4 years. And this is the period that is ending this year. And as I said, tremendous opportunity for us to start to see the kind of result coming forward from phase 2, which is a full implementation. And it is in that phase where the projects started to expand their reach. So what we did in phase 2 were a smaller number of projects, 9 projects, reaching a tremendously larger group of Canadians across the country, upwards to over 1 million people, in fact, where the 9 projects had on average, or have on average, approximately 300 sites across the country. Next slide, please. About how it's innovative around the scale, and I talked a bit about, I think we're on the slide. So, moving along, this map shows you a little bit about the on the reach of the projects that we have across the country. So you can see across Canada, we have projects in virtually every province and territory. We've got projects running in cities as well as rural communities, as well as in the north and the far north, which really gives us a tremendous opportunity to start looking at what are the particular challenges and opportunities in different populations, but also in different geographies and different social contexts across the country. Next, please. Out the projects. Here you see are the 9 projects that we are currently funding, and they come across in 3 themes, settings. They're looking at family context, cities, and school-based interventions for social and emotional learning. You see on the left side the list of the project leads. Many of them are universities that are connecting and partnering with individual communities. Some of the non-government organizations within Canada, such as the Centre for PHE and Mental Health Association in BC, as well as the Mental Health Association in Nova Scotia, the Centre for Addictions and Mental Health, that are also running a project lead. And again, remember that these are 9 projects that are connecting out across different sites to expand their scale and their reach. You'll see here just a couple of things to note. All of the projects are working with kids, many of them are with youth, and about half of them are also doing programming for parents and caregiving. One point on the far right, the projects, in fact, over half, are also looking at the relevance of cultural adaptation, which is really interesting. There's a couple of projects where that is a specific outcome that they are investigating, but you will see that it's across many of the projects. Next slide, please. A little bit about our process for knowledge exchange. This is a deliberate and active process across the projects and at the program level. So at the project level, it's a very participatory approach and very iterative. So where the project hosts are leads connecting and creating their own networks and systems across different communities and partners across the country, and also starting to measure knowledge uptake and knowledge use, which is some interesting findings I think that will be coming out over the next couple of months. And at the program level, it's about fostering connections between projects. I'll give you an example. One of the projects that is hosted by or led by the Canadian Mental Health Association of Nova Scotia, called Promoting Alternative Thinking Strategies, it's been integrated into the Nova Scotia Halifax Regional School Board, which is one of the largest school boards in Eastern Canada. What they're planning to do in the school board is implement both the PATHS program and one of the other projects, which is called the 4th R, which targets or works with older kids. What we're going to do is measure the impact of engaging children 5 to 12 in one project, as well as youth 13 to 19 in the other project, across school transition periods to maximize the impact of behavioral and school environment change. So that'll be very interesting. It's one of the learnings that are coming out of how the knowledge uptake and exchange can create some interesting synergies. And so we'll be looking more going forward into our scale-up phase of how we can create and explore shared agendas across the different projects with complementary activities. So please. So now what we're learning. I think we have time today to go through each project individually, and we have some information at the back if anyone is interested or has questions about specific projects. We've got an email that you can contact for further information. Just a couple of things very high level on each of the different settings. So on the school-based interventions, where social-emotional learning works, just a couple of things that I've already talked about some of the projects. First, one in Nova Scotia, where it's being integrated into school curricula. This is where we're starting to see emerge how the shift to upstream prevention can start to happen as these types of programs become integrated into systems. The project is engaging teachers and changing school environments compared to the control school. And a major development was the creation of the Atlantic Advisory Network on Social and Emotional Learning to generate policy and program change discussions. With respect to the Center for Addictions and Mental Health program on the 4th R, which promotes relationship development for youth aged 13 to 19, as well as teachers and parents, intervention's been demonstrating a reduction in aggressive behavior, relationship violence, reduction in alcohol abuse, and improved school environment. It's also been adapted to First Nations youth, and developed and incorporated a mentorship training support element for youth that are vulnerable to dropout. So interesting to see in some of these projects how they've been adapted and how the projects, through their partnerships, have been able to take some of the ideas even further. In the area of parenting and family competence, we're also seeing success, and I draw your attention to our University of Manitoba project lead, which has had success at a policy and program levels in Manitoba, creating a testable intervention that can be that's compatible with some of the existing public health nursing programs and operations. And this intervention has also been adapted to cultural needs of urban and rural communities. Slide, please. I'm going to talk a little bit about one particular project in the north. Talk about some of the learnings that we're seeing out of this project, which is a community setting, and it involves youth engagement in northern communities. Run by the Quaj Health Research Center, and I apologize that I don't speak Inuktitut and I don't want to butcher the language, so I've just called Quaj. They are doing a really interesting program that is a Made in Nunavut or Made in the North approach. As many of you know, there are unique challenges and a pressing need for mental health promotion in northern regions. Nunavut is one of 4 major regions where Inuit live in Canada. There are approximately 15,000 Inuit in Canada, and there are significant challenges from a social determinants of health perspective, including food insecurity, poor nutrition, overcrowded and stressful home environments, poverty, just to name a few. Nunavut's suicide rate is 10 times the Canadian average and much higher than that for young men. So there's tremendous need there, and there are challenges working in a northern environment. I think this program has been able to look at very carefully. The intervention has 2 parts. The first is a parenting program, which is essentially, as I said, a Made in Nunavut program that's been successfully trialed in remote communities, as well as in Iqaluit, which is the capital of the Nunavut territory. The second part of the intervention are camps that are held in English as well as Inuktitut, which is the Inuit language. And they include Inuit traditional activities and activities that are encouraging team building. And they're really starting to see this opportunity and results from these types of programs that are really community-based. We're excited to see where this type of program goes. I looked at scale-up and some of the challenges of scale-up in a northern context. There are unique challenges with respect to relationship building with policymakers, but also opportunities. And I'd say one of the biggest opportunities with respect to working in communities in New York is that strong sense of community. Next, please. This is some pictures that have been provided to me through the project lead in Quaj. So you'll see a picture of Iqaluit. As I said, that's the major center in Nunavut. Next slide, please. and of the kids in the camps doing some of the programs together. Next slide, please. So where do we go from here? As I said at the beginning, we're at a very exciting place in this project, in this program, where our mental health promotion phase 2 projects are wrapping up, and we're at a point of getting, bringing in all of the learnings and looking at how we can synergize and synthesize this kind of information and get that information out to broader audiences. We're also looking at scale up for phase 3 of the school-based interventions. And I'm excited to see not only how these interventions can be scaled up, but also evaluating the process of scaled up and what works and what doesn't work. And we're starting to see some trends emerge in that area already with respect to the importance of enabling projects to create lasting, sustainable partnerships, vested partners, having champions for scale-up, so that these programs and ideas can be integrated into mental health programs and systems, but not only that, across justice, education, and other sectors. Next, please. So this, again, is a picture from the Quaj project. Just a couple things that I'd like to leave with you today as I wrap up. Ultimately, these projects and their success are community successes. The teachers, the kids, the parents, the communities that are running these projects and creating the successes and creating the partnerships. The Public Health Agency of Canada is an enabler. So our role really is to help share the learnings and find out as much as we can about why these programs are working and what is the best way, or what are the conditions that need to be in place to roll these programs out more broadly so that others can pick them up as well. As I said, it's a tremendous opportunity, I think, to continue to innovate in the area of mental health promotion and build mental health promotion activities across whole populations by expanding networks and creating more lasting partnerships. So that's where we are on the project. I think, as I said, it gives you a little bit of a sense of some of the interesting things that we're doing here in Canada at the Public Health Agency of Canada, and what the opportunities could be to really make that shift into upstream promotion. Thank you. Over to Frederick.
Thank you all. I hope you can hear me all across the world. I'm calling from Sweden, and I would first like to thank Nicholas and Keely for supporting our work in trying to make this seminar as best as it could. And I also would like to thank co-authors that's already been delivering to brilliant speeches. In my case, I wanted to address a few of the issues that really are part of my work within the National Strategy for Mental Health, which is a particular kind of construction we created. And I'd like to discuss how we try to work with population mental health, with governance arrangements that actually can deliver on some of those things that both Gregor and Steph was talking about, as well as talking about a little vision around how we need to bring scaling, innovation, all those kind of things to the forefront to be able to have any kind of success, which both Gregor and Stephanie was clearly demonstrating some innovative approaches to. So in my case, let me change slide, please, Kitty. So speaking from the perspective of one integrator, which is actually the team I'm working with, which actually placed just between all levels of this three-level administrative division of labor between national, regional, and local. In Sweden, local and regional have a particularly strong position, although we are a unitary state, so we have two levels, which is clearly something like the one from which Gregor and Stephanie is speaking from, and we have a strong local and regional level, which actually has now come into agreement around a mental health strategy, which is one of the first sort of ambitions in this way for Sweden since a long time, which is really interesting. We're now approaching the first three, and we're now asked to be thinking about, together with the Ministry of Health and Social Affairs, to sort of start looking into the future, maybe a 10-year strategy for mental health, where I believe we want to add the particular need for intersectoral work, as well as the work on promotion, prevention, early identification and intervention, both high and in terms of problem development, as well as keeping an eye on the quality of psychiatric services. So there's really a whole range of different stuff we try to do. And the whole mechanism of how we want to do it is to try to integrate first decision-making levels and other ways. That's the only way we can see that we have any chance to affect the outcomes we want to achieve changed. Please, next slide. So what is the major driver behind this work? Well, I would say we've actually reached a situation where we have to move mental health from individual's problem to a collective challenge for all sectors of the society. And that comes both from the perspective that Gregor was referring to in terms of mental capital, the need for a population to be able to work and use in every person's ability to contribute in the best way they can, both for their own well-being as well as for the society as a whole. And certainly it's a central question for the economic development of cities, regions, and the society as a whole. We're estimating right now in international comparisons that countries are spending 4% of their GDPs on mental health as a problem, which is a sizable, certainly a very sizable part of the national domestic product. Interestingly enough, mental health is probably the sector and the problem part where most of the challenges actually come in different parts of different sectors. So it really has a very, very tremendous effect on all parts of human life. We all know, and that's been shown clearly by others within the corporate centers, there is a high need to start working much more on prevention and promotion. We have knowledge about how we can address a few of these things. We need some more, but there is a lot of things to be done already. What we have, the problem for us not reaching there is actually we set up the appropriate ways of governing these kinds of systems. We haven't looked at the appropriate incentives. We haven't looked at the appropriate disincentives. So we have to build much more sustainable processes of improvement together between sectors. Next slide, please. Our sort of mantra has been don't wait. And that's true for both we start act now, as well as we have to start act as early as possible. Intervene earlier, reach broader, use all policies, and be much surer to use steps that can help us achieve outcomes. And to get this work for, particularly for children and youth, we have a lot of the similar kind of thinking for adults, but I didn't have time to present on those as well. It's really to think together between sectors, to really unite around how we build the systems that are able to deliver the services that actually is much more appropriate for the people living in our country, in our communities. Is usually not done best by the traditional silos. We should do that with a better holistic picture in mind. And if we want to have that, we need to develop appropriate governance mechanisms to make that possible. It just will not happen without those kind of adaptations to the way we run our services and businesses at the moment. Next slide. This stuff talked about for a long time. The question is, how can we make it into core businesses, not just a pro phenomenon for some true believers? It really comes in the fashion of changing appropriate ways to approach the problems. We have to start from the top. There's no chance to be changing systems so drastically without trying to reach to those most centrally placed to make decisions. In our case, most often politicians elected by the population. They have to be not decentralizing, but actually looking at what are key features. Then, with the rule of improvement presented by the politicians, they have to engage all other sectors to try to figure out what should be done. But it not be stuck in a very limited part of the system. It has to be front and center and hot in the governance to make some realistic opportunities to survive and change happen. It's also certainly important to think about both the need for directions, but also the need for actual change mechanisms. Know how we can make those wonderful ideas presented to us realistic and actually happening at the scale we want them to do, and to have them deliver the results they have to be delivering. To do that, we both have to understand the counter forces as well as drivers for improvement. There's a lot of stuff right now in the ways our systems tend to work that this incentivizes that kind of problem, and we have to be able to be acting drastically on those kinds of things. Really a lot of stuff that drives towards particularization, not a more coherent, generalized picture. And economy is one of them. How budget, how we work around cycles. Why can't we have an agenda for investment for a much longer time than 1 or 2 years, which we need to have in order to be able to make some changes of the nature we're talking about. Next, please. This might sound very fluffy and maybe like something that's possible to achieve. Let's actually quote from someone who was speaking, a psychologist speaking about procrastination. I think it's a really wonderful line. We have to start. We have to start testing, and once we start, we might find that it's not that bad. We actually are going to be able to make changes in a realistic time frame, but we have to be consistently working together to do it. Next, please. Examples. This is the first one. We were asked to work with the local community to think about their strategy to address the social problems they've had, and that actually was coming from all sectors: social justice, education, employment, everything. Yes, things seem to be working well in this particular community, which is part of a larger local authority. Well, the problem is not the lack of engagement. The problem was actually when we started working with them, the way they tried to make change, how they were actually not working, sharing the same targets and same outcomes. So we had to get into a sequence of doing first a labor in decision making. Next slide. To make what kinds of decision and that and create that together between the sectors of society at all appropriate levels. Next slide, please. We also need with appropriate data so that they could track their own development over time. This is an ongoing project, and it's certainly not as portrayed as here. It's much more challenging to make it, and we're right now in the process. What we're able to do is to back this improvement process with appropriate indicators and having the group of statisticians and others to work with the steps they have to show the picture and the estimated needs for improvement and the gaps that need to be fulfilled. Next, please. This up with this data for right at the right moment for right person. And this is mapping that. Next, please. What I find is that we do have resources, but they tend to be bound up very far and treatment, not into prevention, and where we need to have stuff in order to make a scale change and the prevention efforts really happening. We've been stuck in a position we created for ourselves a lot in Sweden, where we're bound up with costly services for problems we could actually sometimes prevent. with much better human and economic effect. Next, please. So to develop so investment funds is the way we're portraying it. They may come under different names, but they do address the question of how can we some pooled money that we can invest in prevention and promotion between sectors to overcome some of the problems we've had to between sectors rather than maybe within the sector. And to make it possible, we have to have investment money that we use smartly and then guided the funding some of the innovations we wanted to see or have. And this is a process that's been happening in about 50 local authorities in Sweden in different kinds of ways. And it's a way of overcoming this idea of doing projects but not being able to actually implement them or scale them up. Next, please. So in order to be able to invest, we have to be able to find a few new kinds of capabilities in the system. We have to have better ideas. We have to find and cultivate people from all kinds of stretches of society that have ideas for good solutions. But those ideas might not necessarily come together with not about how you make programs that actually can deliver results. You have to have technical assistance for the design process, like what Stephanie was describing in the health of Canada's innovation strategy. Investment funds actually do, they're governed by local politicians and management in these local authorities. And what they do then is that they can address the particular gaps that they find are needed to be addressed. And they can direct money for those particular kinds of problems that they have in their particular community, which is really important for them because they're really, really not the same all over the place. So with some technical assistance, appropriate process either of innovating new stuff, but pretty often look around in the world or in Sweden to find what have others tried. They should try themselves and actually make them actionable programs that can deliver results. They have to work systematically with evaluation to really learn from this practice, both at the program level, but also how the system actually does perform. And the key of having senior management highly involved in politicians that they would immediately start to see what problems exist and the frictions between jurisdictions or frictions between sectors, that they usually get to see that clearly. When they see a program addresses the problems, they might themselves actually see in first-hand experience what problems they're experiencing. And you have to start preparing the test process. And what is central here is that it would to be so that project money would come without the requirement to implement what you learned. With that, you're creating a mess of problems with, because it's not necessarily so that services do enough. They tend to adding to what already exists there, and sometimes they're actually not appropriate services delivered and should be into much more well-functioning ones. And the mechanism of social investment actually can set those kinds of requirements and therefore address the challenges of ending something when you're introducing something new. The mechanism of making that the process much more clear and there is certainly frictions around, but the clarity of this process is actually helping to see what Sugai we just learned is the idea that for every new intervention you should get two of the ones that this is phasing out. There is no chance with resources or skills or whatever to delivering everything. We have to find the best things that really can achieve the changes we want to see. And with that, I would like to end. Thank you. Gary Belkin, United States.
Frederick, thank you, everyone. I appreciate being last because I can just reference some of the really great and important ideas and principles you've been hearing. Try to fill in where I see are some of the cracks in actually implementing some of the ideas and starting in New York, a little behind my Canadian, British, and Swedish colleagues, but taking advantage of a lot of the ground they've paved and thinking innovatively about how government really impact and strategize and design itself to impact the public's mental health. Next slide. Before after here is how to have everyone share this burden. This is study data from the global burden of disease, the latest global burden of disease calculations. Years of life lived with disability on the left, men and women, and on the right, the DALY, summary of DALY, appointment by disease categories globally. And the take-home message here is the red. The red shows the contribution of common mental disorders, substance use disorders to the total burden, again on the left, and to the death-adjusted disability burden, mortality-adjusted disability burden on the right. And so the core question is, can we get all policymakers to shrinking the red and share ownership of them? You've heard, I think, some key ideas that need drive government to succeed in that way, such as how do we these needed and methods to shrink the red are embedded throughout other areas, and here described, and also packaging accessible best practices for broader use and dissemination. How government contributes to innovation and testing, best practices for implementation and scale. Stephanie described, and also, how to build government to be nimble and cross-sector and fund innovatively to think this comprehensively and to create the levers to indeed share ownership of this burden that Frederick described. We are starting to think about how to build these drivers, accessible packaging of best practices, being an innovator for scalable ideas, and designing government. But also really thinking about some of the practices that can lend traction, those indeed becoming the new drivers, with an eye towards, which hasn't been spoken as much, and so I'm going to right here, especially how to bring existing structures along, particularly the treatment system, as a platform, broader, more upstream impact and supporting and promotion. In this city, we've really fitted by the attention of the highest levels of government here and think more comprehensively about mental health in a population way, and then also rethink how government can drive more comprehensive approaches and include more of government and the whole of government into mental health. A picture of our First Lady, our city's First Lady, the wife of our mayor, Cray, who is also the chair of the New York City Fund to Advance New York City, which is important because that's a real incubator of development and new policy ideas in the city, including bringing together public-private partnerships for developing innovative ideas in the city, policy environment here. And so to bring that connection, as well as pulpit and connection with City Hall, to bear on thinking more innovatively about mental health is a real bonus. I think cultivating that kind of leadership, having others lead, this idea of bringing mental health to all policies and thinking much more expansively about a population strategy, others lead on that, I have found to be really strategically and effectively. We've been able to benefit from that here. So the idea is set out with my department and others to frame a strategic plan for New York City to envision this kind of all-in idea. How do we bring shared ownership around shrinking the lid to be part of how New York City works? And in addition, again, to the ideas that my colleagues have presented, I'm not going to, but they're really critical. Attention to the ideas they put forward, but I'm going to add a few that go, at least help me remember them, by the 3 M's: better measures, better models, and better management. Starting the next slide. So I think that experience, we work on very limited data that's not up to task of organizing, coordinating, and envisioning for a broader set of stakeholders how to act this idea of government responses to population mental health. We're going to change that. I'm curious to hear about other efforts, particularly at city levels, to chat. Greg mentioned efforts that he's been working on to merge data sets. I know that's happening elsewhere. On the left is a map of by city public school districts that actually show the density of psychiatric ER visit risk among youth, which is a sort of composite and hybridizing of measurement how to connect these very different type of executive opportunities for action, the public school sector and the health system, to try to work together and see that they have overlapping areas to work on together, a way that is both visible and also actionable. Right is a graph of data that we get from surveillance of activity in our emergency rooms throughout New York City, where we're able to text and otherwise code the intent and purpose of visits on a daily basis. This is a fairly dramatic view of a spike in presentations for related withdrawal, which occurred. We had a very large storm here in New York City a couple of years ago that alerted us to the fact that a lot of our methadone providers had closed. And so this is a very real-time ability to behavior in the system and needs in the population that were quite actionable and were accessible by a wide variety of actors. So the healthcare system could see this, the mental health providers could see this, emergency responders could see this, and we were able to act in concert. I often think, and we are thinking about how to build on these practices of more real-time surveillance and creative mapping to create some of the traction and actionability that's really needed to realize the kinds of embedded and whole government approaches to population mental health that we're talking about. As I mentioned, and also models. We need to, I found that we really need to change the language that we talk about to bring others in. If we want to bring others in, other sectors, other actors, into share ownership of shrinking that red, we need new language that captures a much broader causal map action for mental health. And so we've been in New York City looking a lot at work on neighborhood effects, on understanding efficacy, and how neighborhoods and social groupings are potential object intervention. A lot of attention, especially how that plays out with in early childhood, which was mentioned by several of my colleagues as a evidence-rich and high-impact area to focus joint whole government sort of action. And we're also trying to look at how we leverage the energy investment and resources of communities as partners with government to be agents of change and innovation. You picture at the bottom right from an effort in Scotland to scale early child and early parenting support packages throughout the country using a learning collaborative method that brought approximately 40 cities together that were cross-sector and highly represented, really to be co-players of solutions and sources of innovative policy ideas. So these more collective models, more environmental and ecological exploratory models have started to grow in use and in conversation and across city agencies. It really allows many more people to participate in a conversation in a tangible way than had been happening with talking about these based models and talking about usual strategies and definitions that we tend to use in the public mental health world. Next slide. Several of my colleagues have identified the need for new management strategies, and Frederick in particular really, I think, gave us a sense of new kinds of principles for governance to really organize about how to reimagine the way multiple government can work together, can identify together and track them over time, which is really a important hurdle to overcome in comprehensive whole government approaches to mental health. We're also become of the decade experience now in the health and all policies movement and the strategies and some evidence that's been emerging from approach in public health around frameworks and ways of structuring government to bring all of the parts of government together to set agendas that recognize the contributions that they all have to impact health. How we have what lessons are learned from that to apply to mental health, and also learning about other country and city level efforts. I have a picture here from another part of Canada. The Ontario's work with provincial support program really sees the role of government in terms of being a support partner to provide platforms, sharing evidence, community-based partners, and also by hosting opportunities for those partners to improve and test innovations a rigorous way. So each of those represent, I think, key principles of new management practices, rethinking governance, and rethinking the relationship of governance to the existing resources in the community. Which gets me to my next slide, please. Also, in not losing this discussion of population level and policy-driven and strategies, losing sight of the rich resource of the treatment system play, and still has to play, in a population approach. I think we estimate and under-partner with the treatment system as a platform for earlier intervention and for promotion and prevention activity and capabilities. And we're being very mindful here in New York City how to take advantage of that and think about both the funding and policy lenses that can help bolster the capabilities of the treatment system to partner in a way. Here a photo just to remind us all that everything old is new again. This is a organizational map of an effort in New York City in the 1930s that set up local health department hubs throughout the city to be host to a whole array of community-based service, voluntary agencies, as well as provider groups to reintegrate and collaborate in impacting and achieving certain population health goals. So it's an old idea we're trying to return to. And the next slide. The biggest impact we had so far in New York City, or the biggest reflection of starting to adopt some of the ideas and principles, really happened in the early childhood, in impacting early childhood outcomes. The established ladder, what's been called a children's cabinet, which really tried to fill this space of governance mechanism to bring multiple agencies together that touch on and are needed to try to address early childhood programming and interventions that work. One of the signal accomplishments so far has been to create an opportunity for universal free pre-K, pre-kindergarten in New York City, and to start using that as a opportunity to not just provide that early opportunity for New Yorkers, but also that as an opportunity to evaluate strategies that work to really bolster opportunities and to also learn more about a population that had otherwise not participated in this, of what services that they have to drive further work. Also out of the Children's Cabinet was an effort to, as I said, bring in the treatment system as a platform. We're looking at ways, for example, which I think is ideally suited for the treatment system to host childhood interventions, especially around, you'll see a logo here on the slide of the Circle of Security program, which is an early intervention of parent coaching and pro-attempt behaviors, in ways that we can build that in to provide settings as a way to spread and scale its use as provider and community-based organization collaborations. This intervention that can be provided peers and so can also be widely spread through other agencies and other parts of government, especially partnered and supported by the treatment system. And finally, you'll see repeated, as I showed earlier, of the Early Years Collaborative, the Learning Collaborative structure in Scotland as an effort to apply quality improvement methods to scale early child interventions, and New York City is going to embark on exactly that path as well in several neighborhoods strategy. So here's our example of bringing some of the principles of better government that my colleagues have talked about here in New York City on this early population as part of a strategy to grow government more in these and innovate more in these directions. So with that, I'll hand it back to our host.
and the presenters that came before. So we have a little bit of time for questions. So I'm going to ask each presenter one question now. The slides will be posted as you have heard, and so will the webinar itself. So if you do have questions that come after that you'd like answers to, please send in to Keely Brack, whose email address you can see in front of you, and we will work with each presenter to develop a Q&A answer sheet that we will also post because we won't be able to get to all the questions today. My first question for Greg, our first presenter, was one of the participants had asked about working with family and caregivers and wondered if the programs that you were speaking about addressed their specific needs and concerns, and also, I guess, more specifically around your community well-being practices. Are there any targeted to caregivers?
Yes, thanks, Nicholas. Each of the programs has the responsibility of making sure that their work also is relevant to caregivers. Particular work we are doing around suicide prevention that has a large emphasis on caregivers. So the simple answer is yes, the devil is always in the detail, and one of the challenges that we have in a public health agency is getting the right data, and data for those in a caring role is a difficult and elusive thing to find. So if people out there do have some good information around data, that's really, really important to us to get some sense of the needs of carers and supporters, and on a much more kind of not just quantitative but qualitative basis as well. So a lot's been written, a lot has been said. We need to try and make sure that each of our programs addresses those issues, and some are able to do that than others.
Thank you, Greg. My next question is for Stephanie, second presenter. Based on the experience of the innovation strategy, what are some of the key predictors or factors of successful interventions for mental health promotion?
Thanks. Yeah, as I said in my presentation, we're just at a point in the projects where we are seeing some predictors emerging. I'd say one of the most important things that we're seeing is implementation readiness from the program. What that means is, do they have the right sites in place? Do they have the right management in place? Are they working with the right partners? So, for example, if you've got a fantastic school-based intervention, a social-emotional learning program, it may not see the kind of outcomes that you want to see if you don't have the school board in place as a partner. And see the greatest program, but if you don't have the school board, or if you have in Canada the provinces or the province that you're running the program in on side, it can drastically impact the outcomes. Another is around adaptation, the importance of having a process for adapting some of these interventions, particularly around communities and cultural context. And that is some of the things that we'll be looking at very closely over the coming months of our Phase 2 projects. And then finally, I would say, and this has come up over and over again, the quality of the partnerships. How you vest the right partners with the right programs. And some of our projects have had a lot of success in doing this, and others have had other challenges in creating lasting partnerships. And that, again, will be very critical for us and the programs, the projects, going forward into a scale-up phase.
Thank you, Stephanie. The next question is for Frederick. A participant asked, what does it take to convince top management leaders from different sectors to be motivated to engage in mental health?
I think it's an excellent question, and thanks for that. It's one of the fifth and hardest part of this I've had, I think. And I think Gary was alluding to this same thing. Yes, how can health become something for someone else? So interdependency that we're looking at, we not want them to be investing for us in that sense. It has to be a collaborative spirit where most of you would see that you can identify, for example, for an head of education, clearly that the majority of the problem we have with people not perform well in school can be explained by mental health challenges. So you can work around that. And in the same way, we know that health improvement is related to educational performance. So if I do interdependencies and be very able and innovative in how we speak about it, so we don't lock them into a particular solution that will come from our side. So truly look into a collaborative where we can, at the best, identify shared outcomes. I think that's learning. That's hard, but that's the way forward.
Great, thank you. Next question is to Gary. How do we convince governments to further invest more dollars in prevention and promotion? And are you aware of any specific economic models available for investment in promotion dollars to savings in healthcare dollars?
Yeah, I think we now have a bit of information, and some cities have taken a lead in actually trying to cost it for themselves. What are the social costs? What are their costs attributable to this burden of illness? We're in the midst of doing that for New York City specifically. We were motivated by looking at other cities. For example, the City of London did a city-specific study looking at that. Now, a lot of those projections are still at a early stage of precision, but I think that we're seeing more of that kind of information being made accessible. What I think has been harder is doing the reverse, is to understanding how to prioritize and queue up policy interventions that convincingly relieve those burdens and reduce those costs. And so it's one thing to say there's a real relationship between mental health burden and cost. It's another thing to say we know these 5 things, what that cost impact would be and where it would hit. I think that's really part of the data gap that we have in general that we need to fix. And I think one way to fix it is by building some of the structures that you've heard being talked about, because it's going to come not from a research study here or there. It's going to really come from incorporating and routinizing, looking at those compacts and offsets in real time as we do things. And that means structuring governance and some of the ways that you've been hearing about.
I do have time for a couple more questions. So the next one is from a participant to Stephanie. Participant asked, so evidence-based mental health well-being impact assessment is being used in the UK to engage sectors to increase awareness and understanding of mental well-being and facilitate promoting mental well-being in all programs and policy. You mentioned Public Health Agency had been looking at the tool for use in Canada, and the participant wondered, has there been any advances for use in Canada?
Okay, so this is impact assessment tool. We did do some early work in exploring how that, a similar tool in Canada, but we are not as far advanced as the UK on how that might roll out. So I would say we're still in early days on that. A number of the discussions around mental well-being, positive mental health, and the impact on different policies have really focused on our social determinants of health and the impact on the determinants and where we go from there. So the short answer is no, we don't have a similar tool that is in practice, certainly at a national level on that, but we have been exploring what that could look like going forward.
Thank you. Next question is to Gregor. The person asked, what can employers do to improve workplace mental health, and asked, how is cultural safety included in the work that you do?
Okay, question. So this is a really, really short answer to a very, very complex issue. An employment and workplace program which has external relationships with employers and employer agencies. One of the things that we're working on with them is getting some information. Each workplace, whether it's a small or large workplace, workplace. It's the information they provide to their employees that's really, really important, and also the data they gather in relation to what they're doing to support employee mental health and well-being. But it would be a whole organizational approach to mental health and well-being, where mental health is just one of a number of issues that are addressed through good workplace practices. Single first-line management is absolutely crucial, and here in Public Health England, we've embarked on a one-year program to train our first-line managers. And the other areas are very much around ensuring that we have good employee access services and confidential services for employees. So there's a whole range of things. And Nicholas, in Canada, you've done some wonderful stuff on ecological safety at work, which is really groundbreaking. So I'd encourage people to look at work in Canada. There's an awful lot of information on workplace mental health and well-being. And in relation to cultural competencies, that is one of the components in the management training. And we also have a scheme in England called Time to Change, which is an anti-stigma campaign, and organisations large and small sign up to that. And part of that work is making sure that we have good promotion and prevention policies, but also that the policies are currently relevant. So it really does take a lot of time and effort, quite rightly so, but also relies very heavily on frontline management training and awareness of staff, and making sure that it's one part of a component of overall health and well-being for employees.
Thank you, Greg. You'll see on the chat function that some links to the work of the Mental Health Commission is now in the chat box. That last question does conclude our webinar today, so I'd like to thank all of the speakers very much for sharing their knowledge and expertise with us, and also thank you for attending today. If you did have questions, as I said previously, that haven't been addressed, please email Keely Brack, whose email address is in front of you, and we will ensure that a question and answer one-pager or two-pager is posted on the site. And the webinar recording will be available on the link that you see here on the International Knowledge Exchange Network for Mental Health webpage that can be found on the Mental Health Commission of Canada's website. So thank you very much, and please fill out our evaluation survey after, as it will help us shape our future webinars. So have a nice day, everyone. Thank you.